The speaker we have here is Dr. Asif Iqbal, who is a senior consultant Department of Respiratory, Critical Care and ECMO Services at Apollo Hospital, Kolkata. So you may take over. Thank you.
So, hi friend. Today I will discuss about nutrition, and also I have another slide for DK and the thyrotoxicosis. So let's see how fast we can uh, complete. So regarding the nutrition, you have to know the nomenclature of isocaloric diet, hypocaloric, trophic, and overfeeding. The topic diet you may ask in your practical exam, and in your K-type question also come topic regarding the topic feeding. So hypocaloric or underfeeding, the energy administration below the 70% of the defined target. And isocaloric diet is means the energy administration around the defined target, and trophic feed when you are starting with the diet in a patient with malnourished, you have to give the little you have to improve the little amount of diet to stimulate lasting secretion for enzyme, and it preserves the epithelial tight cell junction and preventing bacterial translocation. So the trophic feed is mainly when you are not able to give the full diet where patient need in pure status, but to prevent the breakdown of the tight junction and breakdown of the microbiota in the gut. So you are giving the little amount of the food, and overfeeding, yes, you are giving more than 100%, and low protein diet, you all know. So, before going to your exam, you have to know the ESPN guideline, clinical nutrition in intensive care. I will just go through the silent point of this guideline, where you will get a question as a K-type question. So you have to know about the guideline. I know that everyone is already has gone through the recommendation, but just recapitulate. The medical nutrition therapy shall be considered all patients staying in the ICU and mainly more than 48 hours. So, first slide regarding what you will need patient admitted in your ICU, and you have to do nutritional assessment at the time of admission, and also you do the mm, do the assessment within 48 hours, and you will start the nutrition within 48 hours. That is the recommendation one. And recommendation two, general clinical assessments should be performed, assess malnutrition in ICU until specific tool have been validated. Next, your recommendation three. I will talking about all the recommendation given in the guidelines. So recommendation three is oral diet shall be preferred over enteral or parenteral in critically ill patient who are able to eat. Otherwise, the enteral diet always recommended first than the parenteral recommendation. Recommendation four, the oral intake is not possible, then early enteral nutrition within 48 hours in critically ill adult patients should be performed initial rather than the delayed enteral. Recommendation 5, if the oral intake is not possible, early enteral recovery shall be performed initiate critically adult rather than the early parenteral. And grade A recommendation, strong consensus, 100% agreement. So if you have a question that when you will start patient and what is your route, sometime the question may be like that, the twisting question that patient had pancreatitis and whether you will start enteral nutrition or not, or advisable that enteral nutrition start immediately. So in that type of question is coming from the recommendation. So recommendation 6, in case of contraindication of the oral and enteral nutrition, parenteral should be implemented within 3 to 7 days. So cutoff things is 3 to 7 days for your parenteral nutrition. Grade of recommendation is a grade B. Grade A means it is beneficial. B means the risk versus benefit is better. Recommendation 7, early and progressive parenteral can be provided interest of no nutrition in case contraindicated enteral nutrition, severely malnourished patient, and sometime like a patient with intestinal obstruction or patient where you are not able to keep enteral nutrition, like severe sepsis, septic shock with multiple inotropic support, you can go for parenteral nutrition. In that condition, you will give the trophic feed to the patient for maintaining the microbiota of the gut, and you will start parenteral nutrition to maintain the calorie and protein requirement. Next, to avoid overfeeding, early full enteral nutrition and parenteral nutrition should not be used in critically ill patient, but shall be prescribed within 3 to 7 days. And then recommendation 9 is continuous rather than the bolus should be used, but the recent guidelines say that they have newer guideline coming against of continuous feeding. The continuous feeding come in the guideline because there is a two thing. One is the burden for the nursing workload, and second is the infection control point of view. That like the continuous enteral feed was given. The new 2024 recommendation, they all they given the both are same mortality benefit in continuous versus intermittent bolus. The grade of recommendation in continuous, again recommendation B. So recommendation 10, gastric access should be used in the standard approach of initial enteral nutrition. Recommendation 11, the patient with gastric feeding intolerance not solve prokinetic agent, post pyloric feeding should be used. So in this line, you may find question that your patient is not tolerating oral the enteral feed, so you will go for the parenteral. So then this will be false. First, you have to try the other manipulation, the modification of the enteral feed by post pyloric feeding or using prokinetic. And again, here another question come that what prokinetic will use. In India, in Asia, we are using the metoclopramide as a prokinetic agent, but it is European recommendation, the erythromycin 250 milligram QID is the dose for the prokinetic agent. And you have to know what you mean by gastric intolerance. So how much the residual volume you will say that it is a gastric intolerance. It could be more than 250. Okay. So recommendation 12, in patient deemed to be high risk for aspiration, post pyloric mainly jejunal feeding can be performed. Then your recommendation 13 is a critically ill patient in gastric feeding intolerance. Intravenous erythromycin should be used, first line of prokinetic therapy. So your drug of choice is erythromycin. Remember that, and you will get question on that. So recommendation 14, alternatively intravenous metoclopramide or combination with metoclopramide erythromycin can be used for kinetic therapy. So the question will try to make you confused between recommendation 13 and 14. So remember, if the first line of prokinetic therapy, if the question is asked about the first line therapy, you always stick on the erythromycin. Next recommendation 15, the kit in critically ill mechanically ventilated patient, energy expenditure should be determined by using indirect calorimetry. So, if the question asked about the gold standard for predicted energy expenditure, then calorimetry will be the answer. And if calorimetry not available, using oxygen consumption from pulmonary artery catheter or carbon dioxide production PCO2 derived from the ventilator will give a better evaluation of expected energy expenditure than the predicted equation. Now coming to recommendation 22, during critical illness, 1.3 gram per kg protein equivalent per day can be delivered progressively. So protein requirement 1.3. The amount of glucose, the recommendation 23, amount of glucose in parenteral or carbohydrate in enteral admission treated in ICU patients should not be exceed 5 milligram per kg per minute. Remember that in a normal situation, your calorie source should be 65 to 70% from the carbohydrate and rest from the your lipid. But in a certain group of patient like a COPD patient and ventilated difficulty winning, then you have to reduce the carbohydrate load, you increase the energy source from the fat to help in the winning. So recommendation 24 is administration of intravenous lipid emulsion should be generally part of a parenteral nutrition. Intravenous lipid, recommendation 25, intravenous lipid including non-nutritional lipid source should not be exceed 1.5 gram lipid per kg per day should be adapted individual tolerance. 26, in patient with one, this is a recommendation for the basal population. Patient with burn more than 20% of the body surface area, additional enteral dose is your glucose lipid nitrogen is should be administered 10 to 15 days soon. Enteral is commenced 0.3 to 0.5 gram per kg per day. Recommendation 27, in critically ill patient, additional enteral dose can be administered for first 5 days. In case of complicated wound healing, it can be administered a longer period than 15 days. Recommendation 28, in ICU patient except burn and trauma patient, additional enteral should not be administered. तुम मैं ऊपर आ जाओ, ठीक है, हाफ एन आवर बाद, ठीक है, हाँ. So high dose recommendation 30 regarding the your omega-3, high dose omega-3 enteral formulation should not be given by bolus administration. You will get question on omega-3 fatty acid, then the glutamine. So you in a true false condition question. So high dose omega-3 enriched in enteral formulation should not given by bolus administration, and also it is not showing in the any mortality benefit. So enrich with omega-3 fatty acid with the nutritional dose can be administered. High dose omega-3 enriched enteral formula should not be given on the routine basis because it has no mortality benefit. So parental lipid emulsion enriched with your DHA and EPA. The fish oil dose is zero point 0.1 to zero point 0.2 gram per kg can be provided patient receiving parental nutrition. And to ensure substrate metabolism, micronutrient trace element vitamins should be provided daily in the parental nutrition. And in the recommendation 38 regarding your enteral nutrition delayed, where the situation you can delay for the enteral nutrition if the shock is uncontrolled, hemodynamics and the tissue perfusion goal are not reached, whereas low dose enteral can be started as soon as shock is controlled with fluid and vasopressor inotrope while remaining vigilance for sign of bowel ischemia. In case of uncontrolled life-threatening hypoxemia, hypercarbia, acidosis, where enteral can be started in patients stable hypoxia, compensated and pervasive hypercapnia and acidosis. All you remember that this recommendation 38 is regarding the your shock patient. Shock, it is not recommended to you give full feed. There is a chance of hypoglycemia and patients suffering for active GI bleed where enteral started when the bleeding stopped and no sign of rebleeding are observed, and patient with overt bowel ischemia and high output in fistula, you will avoid feeding excess distal fistula is not if you are able to give feeding is distal to the fistula, then okay, otherwise you will consider for the delayed enteral nutrition. And recommendation 39 is low dose enteral should be administered in patient receive therapeutic hypothermia, increase in the dose after rewarming, patient with intra-abdominal hypertension without abdominal compartment syndrome, where temporary reduction or discontinuation of enteral should be considered when intra-abdominal pressure will be increased under. So this is a recommendation regarding your intra-abdominal compartment syndrome. If the recommendation is that if the intra-abdominal compartment syndrome, there is a gradation. Grade 1 is the normal intra-abdominal pressure is 5 to 7 uh, mmHg. If it is up to 12, it is a mild. 12 to 15 is a 12 to 15 is a moderate, and 15 to 20 is a high, and more than 20 is a very severe intra-abdominal hypertension. So in a mild cases, you can give the enteral feeding, but you have to give lower volume. And in case of patient having acute liver failure, then immediate life-threatening metabolic drainagement, you can stop or you can wait. And if there is a no encephalopathy, you can continue. So recommendation 40, early enteral should be preferred. Which patient you will give early enteral nutrition? Patient receiving ECMO, traumatic brain injury, stroke, spinal cord injury. Means any patient who, any critically ill patient, the ideal thing is you should start early enteral nutrition. And GI tract is regarding the patient managed with prone position and patient open abdomen, patient with receive neuromuscular blocking agent, regardless patient of bowel sound, unless volume, you can give the early intervening. Regarding the electrolytes, the potassium, magnesium, phosphate should be measured at least once daily in the first week. Regarding the hypophosphatemia, that in patient with refeeding hypophosphatemia, electrolytes should be measured 2 to 3 times a day and supplement if needed. And in patient with refeeding hypophosphatemia, energy supply should be restricted for 48 hours, then gradually increase. So this all about your recommendation of the nutrition ESPN, and I will request all of you to go through the recommendation before entering the exam, because you will get definitely one or two questions on recommendation. So next topic is diabetic ketoacidosis. The lifetime incidence rate regarding diabetic ketoacidosis by incidence is showing that male is predominant, and regarding the hospitalization rate and the case fertility rate is uh, it is hospitalization rate is high. If the hospitalization and the mortality for diabetic ketoacidosis is very high. The registry people of diabetes with youth age of onset, the Indian Registry Observational Multicentric Clinical Base Registry, where 28.7% people diagnosed type 1 had DK at presentation, and 0.6 to 6.6% type 2 diabetes had DK presentation. So unaware type 1 diabetes patient, they more presented with the diabetic ketoacidosis. Serum sodium in diabetic ketoacidosis, sodium is affected by multiple factor in DK. So hyperglycemia draw blood into the ECF and dilutional hyponatremia, glycosuria, electrolyte-free water excretion. There is a hypernatremia, and variable water intake and loss of water by vomit also affect the sodium level. So usually found the sodium disturbance. Physiological calculations suggest the sodium fall in 1.6 milliequivalent per liter for every 100 milligram of increase in glucose concentration. So you will see the dilutional hyponatremia very common in the DK. So you do not uh, do the correction. Just you calculate the actual sodium deficiency, whether you are dealing with pseudo hyponatremia or the actual hyponatremia. Various clinical study estimated that between 1.6 to 2.4 equivalent liter fall. The approximate drop 2 milliequivalent per liter can be taken for estimated serum potassium in DK deficit 300 to 600 milliequivalent expected in this patient. Reason for this deficit: glucosuria causing urinary potassium loss, and the keto acid expresses potassium as a potassium salt, and GI loss due to vomiting. These three main reasons for the potassium loss. And despite deficit, one-third patient of the normal potassium, reason for normal potassium level, solvent drag potassium during osmotic shift, water, ICF to ECF, insulin deficiency, and acidosis. These all cause your potassium coming out from the cell. And free water and the electrolyte deficit, free water in DKA around 6 liter, and hyperosmolartic honk, hyperglycemic hyperosmolar syndrome, where it is higher 9 liter, and sodium also losses because of the hyperosmolarity in honk, it is higher, and the everything's depend upon the osmolality. That's why the potassium, sodium, chloride, everything is a high loss. And also there is a deficit in magnesium, calcium, and the phosphorus. So precipitating factor, some of the common precipitating factor is inadequate insulin or non-compliance, new onset type 1 diabetes, acute illness like infection, MI, CBA, trauma, pancreatitis, and also drug like steroid, thiazide, atypical antipsychotics. These all are precipitate DK. Most common cause either infection and non-compliance in insulin. Symptom of DK: nausea, vomiting, fatigability, weight loss, hunger, increased urination, abdominal pain, drowsiness, and the abdominal pain due to diabetic ketoacidosis. And the association of the diabetic ketoacidosis and acute pancreatitis, observational 100 consecutive episode of DKA. This 100 TK patient life is elevated, ML is also elevated in 21% and 11% diagnosed acute pancreatitis. Sometimes it is a overlapping syndrome and evaluation, initial labs, serum glucose, renal function test, CBC, DLC, and urine ketone, plasma osmolality, serum ketone, ABG, or ECG. Depending on the case, investigation to be sent evaluate the precipitating cause. So euglycemic decay, sometimes you will get the euglycemic decay, hyperglycemia and hyperosmolarity is the general rule of the decay and HS, but certain patient blood glucose can be normal less than 250, such as treatment with insulin prior to arrival in the ED. SGLT2 inhibitor, pregnancy, and poor oral intake, where you will get the glucose level is not very high, but they have the mm, uh, decay. Mechanism similar is increased glucagon and insulin ratio. Treatment involve giving insulin along with the glucose. The diagnostic criteria, which we have found the question on the last day, the diagnostic criteria of the DK, that the blood glucose concentration more than 11, known to have diabetes mellitus. Then K is the capillary or blood ketone concentration more than 3 millimole per significant ketonuria, and A is bicarbonate concentration less than 15 millimole and or venous pH less than 7.3. So remember this diagnostic criteria. And DK can be mild, moderate, and severe, where this chart showing the different level of glucose, arterial pH, serum bicarbonate, urine ketone, serum ketone, effective serum osmolality, anion gap. Depending on that is mild, moderate treatment. Principal management include fluid restriction, resuscitation, correction of electrolyte abnormality, insulin administration, treatment of precipitate given. Fluid management, issue with fluid management, which fluid to be used, how much fluid to be given, and switch over fluid containing dextrose, which dextrose containing fluid to be given. These are the questions you can ask in your Viva table, and also there are some question you will get as a MCQ. So which fluid to be give? Guideline recommend normal saline is the premix potassium, but this is made of reason that potassium administration and the monitoring become difficulty in the ward and emergency. Also, unfamiliarity to use balanced salt solution. So normal saline is a recommendation. So advantage and disadvantage of the normal saline. And we have an advantage decade of experience, and commercially available, and also it is safe to use, cheaper. And disadvantage is hyperchloremic metabolic acidosis called renal arterial or vasoconstriction leading to oliguria and slowing the resolution of acidosis. And compound sodium, the balanced crystalloid with minimal tendency to hyperchromic metabolic acidosis. Insufficient potassium is used alone, not recommended, available and recommend not commercially available with adequate premix potassium, and unfamiliar, not routinely kept in the medical ward. But the thing is that the resuscitation fluid, you can use the normal saline, then you check the potassium, and you check the in maintenance, you can go for the half normal saline. Normally, it's recommended. And balance or solution, the evidence is very less. How much fluid to be give? Deficit correct over 24 hours. So deficit depend upon, you can calculate the deficit, water deficit calculation, or approximately 5 to 6 liter you for DK and 9 liter for HHS. So patients shock give 1 liter bolus, continue 500 to 1000 ml per hour for the next 2 hours and assess the end of 2 hours. If patient is heart failure, based on the dynamic testing fluid responsiveness, CKD or MASD might to be dehydrate, avoid aggressive fluid resuscitation, ultimately decide based on the clinical scenario. So it is not that DKA means you have to give lot of fluid, you have to check the patient condition and which patient you are dealing with, and you check the fluid responsiveness also. When to switch over the fluid containing dextrose, the when RBS fall less than 200, you can add the dextrose. You can add 5% or 10% and keep the CBG range between 150 to 200. We can split the fluid into RL and the half DNS, D5, D10. So low dose versus standard dose insulin in pediatric diabetic ketoacidosis randomized control trial published in 2024. This RCT non-inferiority trial, 50 children aged less than 12 with DKA and randomized zero point 0.1 unit per kg per hour versus 0.05 unit per kg per hour. No difference time of resolution decay, rate of glucose decrease, slight increase hypokalemia in high dose. Bicarbonate therapy in decay when the arterial pH is less than 6.9, decreased cardiac contractility, vasodilation, impairing tissue perfusion. You can use potential life-threatening hyperkalemia, no RCT available to prove the indication. Bicarbonate therapy in decay, despite lack of evidence, many intensivists have personal cut-off pH is 6.9 and acidemia due to decay. Now, monitoring, sorry, H plus donated the keto acid combined with bicarbonate to form carbon dioxide in the water and gas excreted from the lungs and maintain the pH. So essential bicarbonate is replaced by the ketone body. If metabolized, can be gap with bicarbonate. Ketone body equal to potential bicarbonate. So converting to subcutaneous insulin. So initially you are giving the insulin IV, then to be started once patient able to take orally, and the dictum is that when first you start with the insulin, your targeted blood glucose is 150 to 200 and you maintain accordingly. When the blood glucose decrease less than 200, you add the dextrose and maintain your IV insulin till your ketone body is negative from the blood or the base excess is normalized. And once the patient is stable enough to take oral intake, you can go to subcutaneous insulin. And the dose of the subcutaneous insulin depend upon how much local dose is required to reduce or maintain the CBC is between 140 to 180, or gateway you can calculate zero point 0.5 to zero point 0.8 unit per kg total daily dose, and you divided the 80% is the basal and 20% is the bolus dose. You can divide it. So 40 to 50% total dose given as a long acting. Here it is said that 40 to 50%, but our endocrinologist is always recommend to give at least 70% bolus and 30%, 70% basal and 30% bolus. Here it said 50% bolus or 50% basal. So complication, it can produce hypoglycemia, which is quite common if you not have a vigilance to monitoring the CBG. Risk factor failure to reduce insulin infusion rate or use dextrose containing fluid, failure to monitor blood glucose frequently, do not experience adrenergic manifestation. Hypoglycemia is not frequently observed in patients with HHS. Complications, cerebral edema, preventive measure, possibly idiosyncrasy response on the metabolic injury and subsequent treatment suggested method, lowering the sodium and water deficit. Treatment prompt administration of the mannitol and hypertonic saline. So hypokalemia is one of the common complications. That's why you have to replace potassium if the potassium is 3 to 3.5 milligram per liter when you are starting the insulin. Non-cardiogenic pulmonary edema attributed to reduced colloid osmotic pressure result in increased lung water content, fluid overload. DK and CKD and end-stage renal disease on MSD3 might to be dehydrated, chance of fluid overload, fluid to clear insulin renally, increased risk of hypoglycemia, potassium not usually required because lack of osmotic diuresis. Anion gap monitoring might not resolve the resolution of the DK as a CKD itself cause HAGMA, the high anion gap metabolic activity. Amiodarone induced, now coming to your thyrotoxicosis. Amiodarone induced thyrotoxicosis is the iodine induced hyperthyroidism occur, nodular goiter, then thyroidectomy, and type 2 is destructive thyroiditis and corticoid. So recommendation one is amiodarone-induced hyperthyroidism. Hypothyroidism does not require amiodarone withdrawal. LT4 treatment is recommended in all cases over amiodarone-induced hypothyroidism. Thyroid storm or crisis, inappropriately high thyroid hormone action in the tissue, expression and sensitivity of beta-adrenergic receptor resulting in increased response of endogenous catecholamine. Etiology, grave disease, toxic multinodular goiter, thyroiditis, idiopathic pituitary tumor, HCG mediated, sometimes surgery, infection, trauma, diabetic ketoacidosis, radioactive iodine therapy can precipitate thyrotoxicosis. Trigger, thyrotoxicosis trigger is trauma, any trace like systemic infection, pregnancy, diabetic ketoacidosis, severe emotional stress, intense exercise, pulmonary thromboembolism, pathophysiology, increased levels of T4, T3 from thyroid, decrease in protein binding T4, T3 in serum resulting increased free form sympathetic nervous system activation, augmented cellular response of thyroid hormone. Clinical feature, fever, unreasonable anxiety, confusion, delirium, tachycardia, tachypnea, dyspnea, congestive heart failure, cardiac shock, and pleuropericardiac sound, increased systolic blood pressure, skin hyperemia, generalized tumor, diarrhea, nausea, vomiting. The scoring, there are two scoring is available. One is Barch, Wartowski, and the Akamizu et al. Scoring. Thyrotoxicosis not included. Prerequisite scoring center included, not included. Fever. The parameter is fever, heart rate, atrial fibrillation, heart failure, serum bilirubin, and jaundice. So lab evaluation, T3 concentration is elevated in the greater degree than the serum T4, and degree of elevation, thyroid storm, TSH concentration undetectable, hypocalcemia and hematocrit elevated. Treatment of thyrotoxicosis, etiology therapy, first line treatment is beta blocker or propyl thiouracil based option, methimazole or hydrocortisone. Etiological therapy, second line, Lugos solution of the potassium iodide and sodium iodide, lithium carbonate, and carnitine. And supported therapy, repolarizing electrolyte solution, paracetamol, phenobarbital, furosemide, AC inhibitor in case of cardiac failure. Selected cases, assess mechanical ventilation in case of hypoxemia and cool measure cold practice in case of hyperthermia. Treatment of thyroid correction, direct inhibition of the thyroid hormone synthesis. Profile uracil 800 milligram. Then fast dose is 200 to 300 milligram, and methimazole 80 milligram fast dose, then 40 milligram BD. So block release of thyroid hormone from the gland is use of your lithium or use of Lugol's iodine solution. And block of T4 to 3 conversion. One is by dexamethasone 1 to 2 milligram, profile thiazide or propanolol 40 to 80 per oral 6 hourly. Another thing is the remove thyroid hormone from the circulation in cholestyramine is a chelating agent. Cholestyramine 20 to 30 milligram per once daily, and plasmapheresis and peritoneal dialysis, which reduce the thyroxine load. Supportive therapy, there is a chance of hyperthermia, so cooling blanket, antipsychotic, hemodynamic, beta energy blocking drug, propranolol or esmolol, etiologic treatment, underlying illness and angiolysis. Extracorporeal plasmapheresis revise three sessions of the plasmapheresis for a SPAD treatment. The treatment of thyrotoxicosis crisis in plasmapheresis and single plasma albumin dialysis case report. But there is no strong evidence is there. Mortality 10% cases, 25% patient because of congestive heart failure. Thank you. That's all about decay and the silent point of the thyrotoxicosis, which is important, and the recommendation of your ESPN in the. So, if you have any question regarding the nutrition, you can ask me.
Sir, hello, sir. I'm Dr. Mohammed. I have some question. In case of severe sepsis, the patient is getting noradrenaline, adrenaline, and vasopressin.
Yes.
And that means that we cannot cross the mean arterial blood pressure more than 65. So, in which point we have to stop the enteral feeding and
Yeah.
start parenteral
So,
feeding
yeah.
step by
So,
step?
yeah, absolutely.
বাংলাদেশে একদম সবাই এটাই করে, মানে বন্ধ করলে তো খেপে যায় ইন্টারনিস্ট গুলো, বাংলায় বলছি আর কি আপনাকে,
না, না,
ওদেরকে
ঠিক আছে।
কনভিন্স করতে পারি না।
Now, so ideally, when the patient in the triple inotropic support, you should stop when any point of time, if the patient on the triple inotropic support, as per the ESPN recommendation, you have to stop enteral feeding. You can continue trophic feeding to maintain the microbiota of the gut and prevent the tight junction tight junction leaking, but you have to stop enteral feeding and you have to go for the parenteral nutrition for that point of time. The most of the studies showing that it has a good mortality benefit. Otherwise, when you are giving the triple inotrope, the gut perfusion is very less. And if you give the lot of fluid in the gut, then there is a chance of ischemia, bowel ischemia, which is increase the mortality. So as soon as your patient requiring triple inotropic support, you stop parenteral nutrition, enteral nutrition, go for the parenteral nutrition.
থ্যাংক ইউ স্যার।
Any question?
Thank you, sir.
Excuse me,
Yes.
Dr. Asif. I have some questions from the EDIC mock. This thing that I would appreciate if you could help us to review anytime you choose. I can send them down. There were some that were looking quite difficult, but we really need your opinion.
Regarding you are talking about that if you are feel any topic or any question difficulties, you want to help from the faculty for me. Okay.
Yeah, yeah.
So Fatima, do one thing. You make a for like last time you do. You make one group where all the EDIC crash course student will be there, and me, Varun, and Deepak will be there to help them out. Okay, they can put you can put your question in the chat. Okay,
Okay.
in WhatsApp group, and we will try to give you answer in the WhatsApp group, or we will yes, we will give in the chat group only.
Okay,
Okay.
Okay.
sir.
Last
Okay.
last 15 days, it is you rush through the question practice. If you have any topic need to understand, any question you are not understanding, so you can put the chat box. If I'm available, I will type it, or I will give the verbal answer on the recorded things. On if I have some topic discussion, I will do, no problem. Okay.
Okay, sir.
So next 15 days
Ca-
you are with us for any help related your exam. Okay.
Okay, sir.
Thank you, sir.